Hi, so this is Roshan, you know me. So we have been through the breast cancer topic, we have seen the risk factors and we have seen the pathogenesis. Now we are going ahead to the next topic, that is nothing but the molecular pathogenesis has been done. Now we are to start with the morphology. Okay, morphology will be doing prognostic factor, and today we will be finishing this breast cancer itself. Okay, so now before going to that, let me ask you a few questions. Try to answer it in the comment box. Okay, name the genes of modern penetrance. Two genes are there. What are the genes? Okay, name the genes of high penetrance. I want you to tell me 5 genes at least. Okay, I don't want you to. Okay, fine, you can tell me the 5 genes. You can make sure you can write it in the comment box. What is Lee-Fraumeni syndrome? No, which gene causes Lee-Fraumeni syndrome? Which gene causes Cowden syndrome? Are you able to answer this question? Try to ask yourself, then only. Okay, risk factors more than 4. Risk factors 1.1 to 2. Any 2 risk factors. Risk factors 2 to 4. What are the risk factors? Are you able to answer this? Okay, increased estrogen is risk factor of which one? Which relative risk category does it come? Are you able to answer the question? Okay, BRCA1 and BRCA2. BRCA1 is involved in which type of cancer? Triple negative or luminal or ER positive breast cancer? The same question comes with BRCA2. Okay, my last question is which breast cancer associated in men? Which gene is mutated here? Okay, just try to answer it in the comments. Okay, I'll check you. Whoever is answering, I'll check. Okay, yeah, and I'll respond to it. Now we will be continuing ahead with the topic. Okay. Oh, I'm sorry. I don't know why I have wrapped. Okay, normally, we have seen the pathogenesis. Okay, cancers every spread on within, Okay, we have some low grade to high grade. Okay, for example, if I just take the cervical cancer, SIN1, SIN2, SIN3, penile cancer, PAN, that is penile intraepithelial neoplasia 1, 2, 3, prostate 1, 2, 3. So there you see there are some grades here. Okay, there is normal breast parenchyma. Let me call it as a TDLU. Okay, at this stage it is going to become atypical. That means some atypical neoplastic changes are going to take place, right? Next stage it is going to be obviously the DCIS. So this is in the case of a breast. இப்போ நான் சொன்னேன் cervix எப்படி இருக்கும் prostate எப்படி இருக்கும். Now this is the case of a breast. Okay, இது DCIS progress ஆகும். After DCIS it can show me 2 outcomes. One is IDC NOS. Do you know what is IDC NOS? Sometimes they call it as IDC NST also. In your Hirschsprung it is written as NST. IDC NOS means invasive ductal carcinoma of no special type or not otherwise specified. We will first of all see why they are calling like that. Coming up we will see that. Okay, so we have talked about what is DCIS. So what is it? Now you explain me. You will ask. Okay, I will be explaining you shortly. Okay, next. So one outcome in the madri kudukalam. Okay, or that is it can also give me IDC special types. Okay, it is no special type. It can give me other outcome, whether it can be IDC NOS. Most of the cases you see is the IDC NOS only. Okay, and they will just check it for the IDC NOS only. The other case it can be IDC NST. Okay, fine. Now just imagine, or now let us take a terminal duct lobular unit. Okay, is it clear? Okay, fine. So now these are the terminal duct lobular unit. Now ஒரு point சொல்ல மறந்துட்டேன் நேத்தி. Okay, ஒவ்வொரு கேன்சருமே பேஸ்மென்ட் மெம்பரேனை பிரீச் பண்ணாம மெட்டாஸ்டசிஸ் பண்ணுதுன்னு சொல்லுவீங்க. ஆனா breastலயும் prostateலயும் மட்டும் you see if this is the duct, surrounding the duct there are some cells called myoepithelial cells. What are these called as? Myoepithelial cells. ஒரு கேன்சர் breastல invade பண்ணி போகணும் அப்படினா it has to cross this myoepithelial cells, right? Okay, can I say if the myoepithelial cell is preserved, okay, the cancer is inside this duct, can I say that? Yes or no? Yeah, that means the cancer has not metastasized. Are you understanding the point? Now if it crosses the myoepithelial cell and if the myoepithelial cells are lost, okay, if the myoepithelial cells are lost, can I say that the cancer has metastasized? So this is one of the clue which I can find, okay, whether the cancer has metastasized or not. Okay, first of all, now what is DCIS? DCIS na enna? Okay, DCIS is nothing but It's just clonal proliferation of tumor cells. So tumor cells in your it is getting proliferated here. Okay, the tumor cells are multiplying, but it is inside the within the TDLU. Okay, what is this? This is a TDLU, which is a microscopic structure. Okay, terminal duct lobular unit. இது வந்து breach பண்ணிட்டு வெளிய போகல. Okay, that is the meaning of what is that? Ductal carcinoma in situ. Carcinoma in situ na enna? வெளிய போகல, metastasize பண்ணல. It is here inside. Okay, it has not metastasized. Okay, that is what it has not invaded. Okay, invasiveness காட்டல. That is what I can call it as ductal carcinoma in situ. Are you understanding the point? Okay, fine. Now, can I say this cancer has a chance that it can breach this and enter into the stroma? Yes or no? That is when it enters the stroma, then I am going to give the word IDC. What is IDC? Invasive ductal carcinoma. Is it clear? So that means it has invaded. It has invaded into the stroma. Are you understanding the point? Okay, fine. Next. Now you see, there is, can I say, this is one category. Let us see one more rare category. Okay, what is that rare category? Can I say that there is a chance that this cancer can இது உள்ளுக்குள்ளேயே multiply ஆகிட்டு can it revert back and enter into the nipple areola complex? If it enters into the nipple areola complex, then we call it as Paget's disease of the nipple. Okay, it's not the Paget's disease of bone. Don't confuse between two. This is a cancer due to the cancer. Okay, is it clear? So this is a Paget's disease of the nipple. Are you understanding up to this? So let us dive into the morphology. Let us see it in detail. What you have to write in exam first. You have to explain me the DCIS. You have to explain me IDC non-special type mainly and special types to some extent. Very easy. Okay, don't worry. I'll put the picture for everything. Whenever I say picture, the picture will come in the screen. Okay? Yeah. Okay. So shall we move on to the next? Okay. So let us go to the next topic. Okay? Okay. So now let us start with the DCIS. What is DCIS? Ductal carcinoma in situ. You know that these are the TDLU. Okay, so these are the TDLU. You know, right? Now these TDLU. Okay. Now there is a clonal proliferation of cell, and that is limited within TDLU. Okay. So that is what we call it as DCIS. Can we write that? Yes. DCIS is nothing but the clonal proliferation of cells. Okay. That is limited to or restricted to TDLU, that is terminal ductal lobular unit. Are you understanding? Okay, fine. Now let us discuss. Can I say it is within this TDLU and it has not breached into stroma? Can I say that the myoepithelial cells are preserved? So that means here the myoepithelial cells are preserved. Okay, epithelial cells are preserved. Now you understand better, I hope. Okay. Now, what you see it in microscopy. In microscopy, just take the Robbins book. They would have given a mammogram picture and they would have given the diagram, right? What is given in Robbins? Let me explain and let me put the photo. Okay. Now you see the myoepithelial cells are preserved and the clonal proliferation of cells that is within this TDLU. Here you will be seeing a necrosis here that is called as comedo necrosis. What do you mean by comedo? Just think of a pimple. Okay, that means what I meant. See, there are tumor cells. Okay, there are tumor cells, whereas there is a necrosis in the center. That we call it as comedo. Okay, so necrosis in the center. Okay, so that I am going to call it as comedo pattern of necrosis. Are you understanding? Okay, coming to the next. So you see tumor cells and necrosis is there. What type of prognosis it is going to be? It's going to be a highly worse prognosis. Okay, it's a bad prognosis, and also it's high grade tumor, right? Also, if you just see there is necrosis, can I say by chance if there is a necrosis there will be calcification? What type of calcification do you think here it will be present with? So there is necrosis and the calcification. We'll go back to the cellular adaptation chapter, right? So necrosis here, calcification is there means that is type of, what type of the calcification it is? Dystrophic calcification. Okay, it is a dystrophic calcification. Metastatic calcifications are they are homeostatic, right? It will only be with you can discuss what is dystrophic is only related to abnormal calcification. Metastatic is not, it's just a physiological calcification, right? So this is the pathological calcification and this is what is taking place. how will the patient come and present with? He will say vague swelling, right? So the patient presents with a vague swelling in the breast, right? So that is what says that it is a type of DCIS, right? Correct. When you take the biopsy and check if the myoepithelial cells are preserved, then which marker will be positive? How will you say that the myoepithelial cells are preserved? There is a marker called as P63. It's not P53, it's P63. Okay, this P63, if it is positive, then the myoepithelial cells are present, right? Okay, can I say for all the IDCs, okay, and IDC NOS, IDC special types, it will be P63 negative because it has invaded. The myoepithelial cells are now not preserved, right? So that is P63 marker will turn out to be a negative. Are you understanding? So the IHC comes out to be P63 positive. All the notes are with me. I will send it to you once if you text in the, if you comment under the post in the Instagram page. Okay? Yeah. So this is all about this one. What I want to explain is one more finding. Okay? How it's a calcification. Can it be picked up on a mammogram? Yeah, it will be picked up on a mammogram. So these calcifications will be picked up on a mammogram. Okay? So dystrophic, all the calcifications will be picked up on a mammogram. Fine. Will it be microcalcification or macrocalcification? See, within this terminal ductal-lobular unit, so there is a necrosis, means here the necrosis is going to be, okay, right? All these are microscopic structures. So what type of calcification it is going to be? It's a microcalcification. Okay, everything is arising from so it's a single group or single group, correct or not? Or single area. So that is what. See, can you see the picture of microcalcification as I am showing in the Robbins now? I have marked it, right? So you can see the microcalcifications in the mammogram. Very well appreciated here. இதுவே fat necrosis na அது வந்து ஒரு குரூப்ல இருந்து due to a trauma ஒரு குரூப்ல இருந்து அரைஸ் ஆவறனால அது நான் microcalcification னு சொல்ல முடியாது. ஆனா breastல if it's microcalcification then okay, I will do the next work treating the patient, right? Is it clear? Next ஒரு pattern ரெண்டு photo கொடுத்திருக்காங்க. கீழ பாத்தீங்கன்னா ரெண்டு photo இருக்கும். One is called as papillary pattern, another one is called as cribriform pattern. See, cookies மாதிரி இருக்கிறது, that is what cookie cutter appearance. Okay, cribriform pattern means cookie cutter appearance. That is one form of DCIS. Okay, one more pattern you can see, that is a papillary pattern. In papillary pattern, what you are seeing here, that is you are seeing the papillae. Okay, now listen very carefully. This is very important for you to understand the concept. Now I am writing the papillary pattern. Okay, if it is, imagine this is a papillae. If the papillae is having a fibrovascular, okay, it's a vessel. I think so I have a red marker, wait, yes, okay. So if it is now if it is if a fibrovascular coat is present, then it is a papillary pattern, okay. And if there is no fibrovascular core, this is fibrovascular core, okay. And if it is not present, I am going to call it as a micropapillae, okay. So papillary pattern, micropapillary pattern, okay. This cribriform and papillary pattern, all these are low grade tumors, okay, but this one is a high grade tumor, okay. Are you understanding the DCIS? Will you write the points in DCIS now for your exam? Let us discuss the next Paget's disease. Okay. Already I explained Paget's disease. எனக்கு டைம் வேற இல்ல because நான் the special typesலாம் எழுதி explain பண்ணனும். So I am doing this quickly, okay, by writing. Already I have explained. TDLU ல இருந்து வந்து coming to the nipple areola complex, then I can call it as the Paget's disease. You know, right? We have explained it in the first part itself. Now you know it's a rare finding, the spread of the tumor from TDLU to nipple areola complex. Now I will put the picture. Can you see the picture? What can you see? Can you see the tumor cells within the layers of squamous epithelium? As I have written, okay, I have written everything. So you can see the tumor cells within the layer of squamous epithelium, right? By itself, I can say it's a bad prognosis because when you pinch off your skin க்கு வருது, skin என்ன மேல உருவாயிருக்கு, squamous epithelium தான. So tumor cells are, you can see it in the layers of squamous epithelium. Can you see? And can you be able to see that they are large cells with vacuolation and prominent nuclei? You will be rarely you can find. I would have marked, I think so. You just see large cells with vacuolation. Can you be able to see? Yes, but if you just see, these tumors have HER2 positive. Okay, so it's a HER2 positive, so you can definitely treat it. Okay, is it clear? So this is all about the Paget's disease, and how can you clinically, it's a clinical correlation only because it is going to come to the nipple areola complex where you can find the eczema, erythema and crust plus discharge. All these findings you will be seeing it in the patient. This is not much important from the surgery point of view, it is important, but you can write it and add it to the exam. Is it clear? What's the IHC? HER2 positive. But if you want to find anything other than this, in the eczema you can see that macrophages coming to that area, okay, and causing more and more inflammation. That we call it as Toker cells. If you want, you can add it on. Okay, Toker cells. Is it clear? Yes. So next, let us move on to the invasive ductal carcinoma. Are you ready? Now we are going to move on to the next type, that is IDC-NOS, invasive ductal carcinoma of no special type, okay, or non-specific type. Why it is non-specific type? What is that? See, no, breast it is a dormant epithelium, right? Milk produce right? So that is what I am going to call the breast as dormant epithelium. So the tumors can be non-specific tumors arising from the dormant epithelium itself, right? Okay. It can be that, or maybe mutations. It can also undergo special type. Okay, it can also be a invasive ductal carcinoma of special type. Okay, but most of the tumors will be non-specific type arising from the dormant epithelium of the breast. Are you understanding this point? Okay. Now, how will I say this? Now listen, IDC-NOS. First of all, let us see how grossly it is. So in your exam or in your practical pathology, first of all, they would have kept a breast specimen, right? They would have cut it and kept. Whenever it is cut, when you feel the nature, it is going to be gritty. Okay, so that is what I am going to call it as serous. Rough and hard. Okay, so when you touch feel you can know that. So now I am going to call it as serous tumor. Okay, what is serous? It is the gritty nature of the tumor. Okay, gritty nature of the tumor, like a sand you can feel, right? Gritty, the same thing, same texture, right? So that is the gritty nature of the tumor. And this tumor, if you just see, it's well defined or ill defined, it is getting invasive. So it is an ill defined white, right, solid tumor, right? Yes or no? Okay, and also this tumor grossly it is very hard, right? Because since whenever a tumor is showing invasion, it is going to be more and more desmoplastic. What is desmoplasia? What is desmoplasia? Comment it. Non-neoplastic fibrous response. That is very, very important, right? So when I have discussed the neoplasia, okay, everything I have discussed in the neoplasia. If you watch the neoplasia, you will understand everything. Is it clear? Next. Yeah, it is desmoplastic. Okay, it may invade the surrounding stroma. Okay, can invade the surrounding stroma. Is it clear? Okay. Next, what can you see it in the microscopy? See, it's just a non-specific type. So you can just see the tubules, right? So tubule formation you can see. More and more tubule formation you can see. Okay, that's all. Well formed, you can see the well formed tubules, that itself confirm. And also when I was talking about the neoplasia, I have told you 4 features. Okay, so you can see epithelial cells lined by the 4 features of dysplasia. What are the 4 features of dysplasia? Pleomorphism. Yeah, tell me. Pleomorphism, high NC ratio, loss of polarity, then atypical mitosis, right? So I want you to know this because this is important, right? So you are going to apply it everywhere. You are seeing the microscopy in squamous cell carcinoma, adenocarcinoma, colon. You will write glands, their keratin pulse, and you are going to write this only, right? So just try to remember, understand the concept, each and everything. Watch the video of neoplasia so that you will understand. Okay. And here it's a breast. Can it invade by breaching the basement membrane? No. There you will write. But here you can see loss of myoepithelial cells. What is the loss of myoepithelial cells means? What is the marker which is lost? P63 is, yeah, lost, right? Okay. Next, grading. There is some grading called as Nottingham staging. Okay. If you want, you can remember this. You should write this. I don't want you to know about the scoring pattern. I just want you to know. You can remember with the mnemonic T and MTM means not tumor, node and metastasis. Here you can remember with that T, N, M. So that is tubule and gland formation. Since the breast, there will be tubule formation, and you can see tubules, right, in a non-specific type because it's from a dormant epithelium. Then nuclear pleomorphism, obviously, and more mitotic count. Based on this, you have gradings 1, 2, 3. Overall, they will put 1 plus 1 plus 1. So like that, they will grade. Okay, that is notiform grading. If you want, you just remember this in the invasive ductal carcinoma. Is it clear? Whatever I am giving, you can remember that. Okay, is it clear? Now let us learn about the special types in depth. Okay. We are starting with the special types. Okay, that is special types. IDC special types. Okay. Now, what is this first one? The first one, which special type is or breast tumor mucin secrete pannapodu. Okay. What do you think about it? Sorry, there is some more and more mutation, and that is making the tumor to secrete more, that is making the environment more mucinous, right? Now, what is going to happen? Can you see the photo? What I have put in the photo, what I have shown is, you can see that there are more and more tumor cells, right? So these tumor cells I have encircled, they are floating in the white areas, that is nothing but the mucin. Pathingla? So mucin la tumor it is enjoying. Now you see here, so there is mucin fully. Okay, here you see the tumor cells are, okay, now they are swimming in the mucin. Are you understanding? They are swimming in the mucin. So they are not able to move much. So how do you think the prognosis will be? Can I identify it and can I cure it? Yes, it has a very good prognosis. Okay, and it's mucinous tumor. How will you think? Will it be hard? It is soft, okay, it is very soft and rubbery. Are you understanding now? So that is what do you see microscopically? Tumor cells floating in extracellular mucin. That is what is seen in the mucinous carcinoma. Is it clear? Let's go to the next. Yeah, next one is tubular carcinoma. In tubular carcinoma, what are you seeing? See, in tubular carcinoma, you will see well-formed tubules. Okay, we have seen generally in a breast cancer, tubules is present. You know that in grading. But in tubular carcinoma, there is tubules which is more or less nearly equal to 100%. So that is 100% tubules. And are you thinking that these tubules are well formed only, right? Yes or no? These tubules are well formed. So you can see 100% tubules and very less pleomorphism, because these all tubules are well differentiated and nearly 100% in microscopy fully you are seeing the tubules only, right? Are you understanding? So can I say it has a very good prognosis? Because you are finding that only tubules are there, it's a tubular carcinoma, you can see that and you can treat it. So it's a very good prognosis. And one more thing is pattern is there, variant is there, that is a cribriform pattern. It also has a good prognosis. Okay? Okay, fine. Let us discuss the papillary pattern. You know this is a papillae. Okay, and this is a micropapillae. Okay, papillae has a fibrovascular core attached, right? So that you can say it's a papillary pattern. Okay, fibrovascular core, papillae with a fibrovascular core is a papillary pattern, you can say. But in micropapillary pattern, one more pattern is there, which is micropapillary pattern, where there is no papillae. Okay, where there is no fibrovascular core. If there is no fibrovascular core, okay, now you imagine this is the tumor. Okay, this is the tumor. If it grows and grows, இது நல்லா stretch ஆகும். இது வந்து கட்டாயி பிஞ்ச் ஆகி போகிறதுக்கான சான்ஸ் இருக்கா? அப்பனா can I say இதுக்கு ஈஸியா it can metastasize? Can metastasize and spread easily? Can it metastasize? Yeah, so it can metastasize and spread easily. Is it clear? And is it a good prognosis or bad prognosis? Because it can undergo the metastasis very easily. No, it's a bad prognosis. Are you understanding the point now? So this is all about the papillary pattern of variant and micropapillary variant. Okay, now let us discuss the carcinoma with medullary pattern. Don't see whatever I am writing now. Just you focus on whatever it has been. I am teaching whatever I am teaching. Okay, that you focus. Okay, because notes will be given to you once you text, once you comment. Now carcinoma with medullary pattern. What is medulla? Medulla, can I call medullary means soft? Yeah, yes or no? Okay, so there is a tumor, okay, which is going to be very soft. It's a soft tumor, you now know. Okay, soft tumors, can it infiltrate or it cannot infiltrate? It cannot infiltrate. Yes or no? Because it is soft, it can only push. It will just push. அப்படியே வந்து என்ன பண்ணுனா இந்த ஏரியாவை இது வந்து புஷ் தான் பண்ணுமே தவிர it will not be able to metastasize. That is correct. So it is more infiltrative or less infiltrative? Less chances of infiltrating. Can I say if it is less infiltrative, it is less desmoplastic? Yeah, so it can be minimal desmoplasia, it can show minimal desmoplasia. And whenever a tumor is having pushing margins and cannot be able to infiltrate, shall I say it should be circumscribed? So this tumor should be a circumscribed tumor. Are you understanding? Adavula infiltrate panni poga mudiyadu. And what is special about this medullary pattern of carcinoma is you can see sheets of tumor cells. Okay, that means these are poorly differentiated. Okay, these are poorly differentiated. Okay, it's a circumscribed tumor. Listen carefully. See, this is TDLU. Okay, this is a TDLU. Okay, இது எப்படி இருக்கு அப்படினு பாத்தீங்கன்னா இந்த கேன்சர் வந்து எப்படி grow ஆக போகுதுனா இது வந்து இன்ஃபில்ட்ரேட் பண்ணி போக மாட்டேங்குது. இது வந்து என்ன பண்ணுதுன்னா இது கூடயே grow ஆகுது. இது கூடயே வந்து இந்த கேன்சர் வந்து என்ன ஆகுது? It is going to grow. புரியுதா? So this is what is happening in this cancer. Okay, and what is the main important thing is, okay, surrounding this there are theories that the lymphocytes come to the rescue like a army, okay, like a war. It is coming to the rescue and it is preventing the spreading. That's the theory. Okay, there is lymphoplasmacytic infiltrate, so that is surrounding this tumor. Who is there? The lymphocytes are there. Can you see this? So these are all the lymphocytes. So that is why it cannot be able to grow. Okay, அது circumscribed ஆவே இருக்கு. Are you understanding the concept now behind the carcinoma with medullary pattern? Yeah, but that is what sheets of poorly differentiated because more and more tumor cells are there, right? Next, increased mitotic figures. Okay, now lymphoplasmacytic infiltrate. What is the prognosis? The prognosis is good or poor because immune is coming to the response. As well as you are seeing poorly differentiated, both good and poor prognosis is there. Then what can we do? Let's go to the molecular classification. What do they find? They are finding that it's a triple negative cancer. Triple negative cancer are worst prognosis, you know, right? ER negative, PR negative, go to negative, right? So that is what is about the carcinoma with medullary pattern. Let's discuss the two more patterns pending. So we have to learn the next three more cancers. Let us simply finish it off. Meta and change. So now we are learning the metaplastic carcinoma. Metaplasia. You know what is metaplasia? So here the tumor is going to change. What is this going to present with? See, it is going to present this IDC, that is invasive ductal carcinoma, presents with a, what is going to happen? It is going to just change to a squamous cell. Okay, that is, it can become squamous cell. That it's a worse prognosis. First year is good. We have started with the poor prognosis and it's a worst prognosis, right? So it can, because squamous cells or spindle cells, okay, because all these are metaplasia, undergoing the metaplasia, right? Now it's a worse prognosis. Okay, next let us discuss about the inflammatory carcinoma. What do you mean by the inflammatory carcinoma? What are the signs of inflammation? If you know that, you can understand this. Rhubarb, Calor, Dolar, right? So all these are the signs of inflammation. அப்பனா inflammatory carcinoma என்ன நடக்க போகுது? Tumor வந்து என்ன பண்ண போகுது அப்படினு பாத்தீங்கன்னா, you can see it will block the dermal lymphatics. If it blocks the dermal lymphatics, can I say there will be signs of inflammation, erythema, eczema. You can clinically find the patient with that, right? Now one more point I can give you. Okay, the signs of inflammation you can see, and also sometimes the tumor, what is it going to happen means it will attach to the Cooper ligament and it is going to pull the Cooper ligament. If you just see, if it pulls the Cooper ligament, can I say there will be signs of inflammation? This is the breast parenchyma and this Cooper ligament is keep on pulled. Okay, so can it create an inflammation there? That is what is going to happen. Okay, so tumor will block the dermal lymphatics and it will just infiltrate. These tumors are highly infiltrating. ஏனா பார்த்த உடனே அது Cooper ligament குள்ள நுழைஞ்சிருது. Correct தானே? So it is highly infiltrative. Okay, so this tumor is highly infiltrative and it shows a poor prognosis. Okay, it's clear? It shows a poor prognosis. This points I want. And what type of thing? Beauty orange appearance. In the inflammation nalna varudhu. So where will you see that? In the inflammatory carcinoma. Are you understanding the point now? Where you see the pudy orange appearance? Everything I have written. Reddish, warm, swollen, thick skin, pudy orange appearance. Tumor blocks the dermal lymphatics attached to Cooper ligament, highly infiltrative and a poor prognosis. Next, what is lobular carcinoma of the breast? Lobular carcinoma, okay, it is nothing but due to a mutation that is called as the CDH1 mutation. CDH1 mutation, everything has been explained in neoplasia. Just I will revise it. You know, this is nothing but the CDH1. Okay, here E cadherin is there. So these are the cells to which E cadherin is attached. If there is a CDH1 mutation and E cadherin is lost, all these cells will lose the contact. So there is loss of contact inhibition, right? So as loss on out ne அடுத்த tumor cell எங்க see அடுத்த cell எங்க இருக்கு தேடி வந்து இது replicate ஆகும் till it finds the E cadherin. So that is why this cancer arises. Okay, E cadherin loss, so increased tumor cell growth, no tubule formation, because you know all these are tumor cells are individual and separate, right? So it will show an Indian file pattern. Are you able to find the Indian file pattern in the photo or in the Robbins? Okay, now these are ER positive tumors. That means I can give the hormonal therapy, that is SCRMS, that is like tamoxifen. But what is main thing is these tumors can be bilateral. It can spread from one lobe to other lobe of the breast, or it can also go to the ovary and it can become a Krukenberg tumor of the ovary. Also you can see this kind of mutations in the diffuse gastric carcinoma, right? We will come to the stomach cancer at the time I can discuss that, and it's E cadherin loss. But these tumors are, since they are positive, they are gradually good prognosis. They all have the good prognosis. Is it clear? So this is all about the special types. Non-special type we have completed. Now let us go to the next topic, that is molecular classification of breast cancer. Okay, let's start about the molecular classification. Luminal cancers, you know, they are ER positive or PR positive. Why I am writing ER and PR in group? Because gradually ER positive and PR recommend the same. Most of the mostly ER positive and PR positive are recommend. Okay, next HER2/neu, it is negative and Ki67 is less than 14%. Okay, I'll explain what is Ki67. Wait, now luminal we have two types. I'll first of all fill it luminal plus minus and more than or equal to 14% Ki67. What is Ki67? Ki67 வந்து tumor ஓட growth define பண்ணக்கூடிய ஒரு marker, immunohistochemistry marker. All these நான் எப்படி இதெல்லாம் இது பண்ண முடியும் molecular classification based on IHC தான் நான் வந்து molecular classification logic classify பண்ண முடியும், correct or not? So luminal A is plus or minus. So can I say luminal cancers are ER or PR positive? They will respond to the tamoxifen, raloxifene. So these are the SCRMS, right? Now all these are having good prognosis, right? Yes or no? But now you see this is positive, this is positive. You can ask me both are positive, right? But it has any kind of Ki67. Okay, they also have a decent prognosis. I'll accept it. Okay, now this is good prognosis. This is best prognosis, right? Because it's a slow growing tumor also. I can detect it and I can kill it, right? Yes or no? With the help of SCRMS. Now HER2/neu enriched cancers. HER2/neu is positive and everything is negative, right? So here what drug, how can we treat the patient? There is one drug you will read in pharmacology, that is trastuzumab. Okay, so this drug I can give to cure the patient. Okay, next triple negative means all the three are negative. It's a good prognosis or worse prognosis? It's a worse prognosis. You can treat it only with the chemotherapy. Are you understanding this? Okay, so this completes our molecular classification. In the next video of first 5 minutes, I will be finishing the prognostic factors, and we'll start with the fibroadenoma and phylloxera, which are extremely important, and we'll finish off this breast pathology. See you in the next video. Bye bye, and please try to answer the questions which I have asked you in the beginning of the video in the comment box. Okay, thank you. See you. Good night. Bye.